Hey everybody, welcome back to the Cancering Show. Today we're going to be talking about pathology results. This is episode 3 of 3 in our series reviewing your results. If you haven't listened to the 2 previous episodes, I encourage you to go back and check those out. The first is on reviewing your CBC results. Those are the ones that talk about your blood cells. And the second is on reviewing your chemistry results. Those are the ones that talk about your blood electrolytes and liver and kidney function. So I hope you find all 3 valuable. They're each valuable in their own right. And today we're going to be talking about your pathology results. Enjoy the show. Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. In this day and age, there's a law that says that your report should be available to you as soon as possible. And that means that hospitals now have to release even your pathology reports, possibly or probably before the doctor's even seen them. And that can be really scary. It's one thing to look at your labs or to look at a radiology report and be able to say, okay, I'm going to discuss that with my doctor. But it's really hard to pull up a pathology report, see the word cancer, and it's Friday, it's 5:30, and you don't know what to do or who to ask. And then you turn to Google. And that's the one thing as doctors, as cancer doctors in particular, we tell you not to do, because you find a whole lot of very non-specific information that may or may not apply to you that can be very, very scary. And we really want you to be guided by your specific case, your specific information, and to know that even pathology reports can sometimes be wrong, inaccurate, or incomplete. So let's dive in. First, you're going to see on a pathology report the location. This might be a biopsy or a complete surgical specimen because you've just had an organ removed, like a kidney or a hysterectomy or a prostate. And so you want to check that location and see where the biopsy or that diagnosis of pathology is coming from. Because if it does say something like cancer on it, you want to know, are we talking about the breast itself or are we talking about a lymph node that was removed? And so you're going to look for that location first. And then under location where it gives you a clinical site, like I said, like uterus, kidney, prostate, breast, etc., then it's going to have diagnosis, and it's going to have that diagnosis in almost every pathology report that I have seen. It's going to have that in big, bold letters. And that diagnosis is going to say not just whether or not it's cancer. You will look for words like benign, that means not cancer, or malignant, and that means cancer as well. And there's a lot of words that do mean cancer. To go through a couple of them, it might say malignant, it might say carcinoma, it might say sarcoma. All of those are types of cancer. And then there are other things that have oma in them that are not cancer. So, for example, if it doesn't have the word cancer in it, if it doesn't say malignant, it probably is not cancer. For example, a seroma, a lipoma, or a cyst adenoma. All of those are benign masses that get biopsied. So if you really don't know what that word means, it is okay to Google the word. But remember that might or might not apply to you. But to Google definitions of words is always okay. Now, when you have that diagnosis, it's also going to give you some qualifying statements. So it might give you further information that is descriptive about a cancer. For example, in my line of work, I see things like papillary carcinoma, which is different from clear cell carcinoma. For other doctors, you might see a liposarcoma, a fatty sarcoma, which is different from an osteosarcoma, a bony sarcoma. So those descriptive words in front of the cancer word are going to help you to decide where the cancer is coming from. And again, you have an organ that is biopsied, so that might help you to know what type of cancer cells. You might also see words like metastatic. Metastatic means that that cancer has spread from somewhere else. And that usually is when they find a type of cancer in an organ that's not a cell that started there. For example, you might get a biopsy of the lung that says metastatic ductal carcinoma, consistent with a breast primary. So all those words are very descriptive to tell both the doctor and ultimately the patient that this is cancer from the breast. It is a ductal type of cancer cell as opposed to lobular, and that it most likely started in a breast. It obviously doesn't tell you which one because what you biopsied was the lung. Okay, so all those words are very descriptive. There's a last piece of that description that is present most of the time, and that's what's called grade. The grade of a cancer cell is how it looks under the microscope. So grade is 1 to 3. You're never going to see a number higher than 3. And 1 is what we call well differentiated. That's a fancy term for looks almost like the normal stuff, but clearly it's cancer, but it hasn't gone that far away from what the normal tissue looks like. So for example, for breast, it still looks like a duct. For our uterine cancers, for example, it still looks like a gland, but clearly has cancer cells in it. Now, that's different from grade 3, or what we call poorly differentiated. And poorly differentiated cancer looks so abnormal that it's all blue cells, cells with big nuclei. They're all packed close together. And that can be very hard to tell where it came from. For example, there might be a biopsy that says metastatic, poorly differentiated carcinoma, and they actually don't give you any additional hint as to where it might have come from. They know it doesn't look like a lung tissue, but they're really, because it has no identifying feature similar to its primary location, that they really can't tell you where it came from. And this is where it's important to know kind of where to look in your pathology report and how your doctor is going to help to diagnose you. And that's where we get to things like comments. And there's a comment section under a biopsy that talks about, in kind of sentence form or descriptive form, the pathology is communicating with your doctor to describe it further. And a lot of times in these comments, they might say where they think it might have come from. They will talk about various what we call stains on the cancer cells. And that is when we use particular antibodies that are tagged with a dye to see if they attach to that tissue. And if they do attach, that helps us to say, okay, well, this tissue has these certain proteins that are more commonly found in gynecologic tissues, or they're more commonly found in lung tissues, or they're more commonly found in prostate tissues, whatever is the one that we're trying to identify. And so that helps us to get to that hint of where the primary cancer might be. So that's what you're going to see on a biopsy type path report. Now, last thing to cover when we get back to those pathology reports that are specific to an organ that has been removed, there's going to be a couple of other pieces on there. Now, this is when you have a much larger specimen. You've removed, for example, the whole kidney, the whole breast, the whole prostate, the whole uterus, and you're going to get a very detailed description of that mass and that cancer. So at that time, once they've removed the entire organ, they're going to give you specific information about the size. They're going to give you specific information about how much or how deeply it invades the tissues. They're going to give you the one thing that every doctor is looking for, what we call lymph or vascular space invasion. It might even be abbreviated LVI or LVSI. And that indicates if there's a risk for spread outside that organ based on the fact that they saw cancer cells in your lymph channels or blood vessels that were inside that organ. So this means we haven't looked at your lymph nodes. We don't know for sure, but we saw cancer cells floating in these channels. They're already on the highway. And if they're on the highway, then we have to worry that they have found a way to escape this organ. So whether or not your cancer has lymph or vascular space invasion will play a key role in whether your doctor recommends additional cancer treatment. And anytime we're doing what we call a cancer staging operation, we also are going to have that listed. The pathologist is going to help us all out by listing in detail the specifics of how they come to staging your cancer. And so at the bottom of your pathology report is going to be a long list of factors that are associated with that stage. And it'll take into account potentially other pathologic specimens that you've had done over the last weeks or even months, whether or not you had any what we call washings done at the time of that surgery, whether or not you had any fluid drawn off of your abdomen or off of your lungs, whether or not there was evidence of metastatic disease on a previous biopsy or on a previous imaging study, whether or not you had previous chemotherapy or previous radiation treatment or previous surgery. All of that is taken into account when they look at the staging. And at the very bottom of that long list of each factor that comes into the staging, they will have final stage. And it will list for you that final stage. And it will have what we call TNM staging. And that takes into account the T is the stage in terms of location. So what I mean by stage is two things. One, how far the cancer has spread from its original site. And there's some basics that apply to every cancer. Stage 1 is limited to the organ of origin. Stage 2 is local spread. So it's kind of broken through the membrane or broken through the extracellular tissues outside of that organ. Stage 3 is often regional spread, where it has spread to lymph nodes. And then stage 4, of course, is distant spread. Stage 4 being the worst prognosis, but also still very treatable for most patients in this day and age. And we want everybody out there to know that regardless of stage, in every cancer, there's always a treatment option. And it's always worth discussing with an oncologist what those options are. And we are moving into a time where even stage 4 can be a curable cancer. And so we want everybody to know that and to always seek those options regardless of what stage it is, even though talking about that can be very scary. The N stands for lymph nodes. So you'll see NX if your lymph nodes have not been sampled, N0 for sampled lymph nodes that are negative, and otherwise 1, 2, etc. And M stands for metastatic disease. So we'll say MX if no metastatic sites were sampled, or if you have not had your imaging done yet, and M0 if you have ruled out for metastatic disease, and of course M1, etc. So that is the very brief outline of what you're going to see on a pathology report. Of course, there is a lot more to be said for that. And like I was saying before, do not put too much stock in the pathology report itself. Number one, everyone deserves interpretation by your physician. Number 2, there is many a time that I have called a pathologist back and said, I absolutely disagree with this report. We need to go back. We need to do more tests. We need to do a consultation. So please, please, please have that conversation with your physician. Really wait for that confirmation from them that this is the right report and that they agree with the pathologist's interpretation. And last but not least, know that every diagnosis and every patient has the opportunity for treatment in this day and age, and there remains a lot of reason to be hopeful. So for all of you out there looking at your pathology on a Friday night, it is a Friday night here. And what that means is you want to get together your list of questions. You want to have that ready for your meeting with your doctor when they go over the pathology report. But by no means is it the end-all, be-all, and the final diagnosis. I hope you found this episode helpful. For those of you who are caregivers, I hope it helps you to care for your family members as they go through their cancering journey. For all of you out there, take care of yourselves, keep cancering, and we'll be back soon. Thanks again for listening. And don't forget to submit your questions at www.cancering.com. We're here for all of those questions and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.